I will talk about session 11 to 14, and this would include the steps 5 to step 10 of the 10 steps of a successful breastfeeding practices. We now go to session 12, breast and nipple conditions. At the end of this session, the participant will be able to list the points to look for when examining a mother's breasts and nipples. Second, describe causes, prevention, and management of engorgement and mastitis. Third, describe causes, prevention, and management of sore nipple. Lastly, demonstrate through role-playing, assisting a mother with breast or nipple conditions. So, examination of the mother's breasts and nipples. During antenatal checks, a woman can be reassured that most women's breasts produce milk well regardless of size or shape. Always observe the condition of mother's breast when you observe a breastfeed. If you physically examine a woman's breast, explain what you want to do. Ensure privacy to help the mother feel comfortable and consider customs of modesty. Ask permission before breasts are exposed or touched. Talk with the mother and look at the breast without touching it. So it is important not to touch the mother's breast while doing the examination. If you need to touch the breast, do it gently and ask permission. Ask what has she noticed about her breasts. Is there anything that worries her? If so, ask her to show you. Talk to the mother about what you have found. Highlight the positive signs you see. Do not sound critical about her breasts. Build her confidence in her ability to breastfeed. So ask, how did breasts change during pregnancy? If breasts become larger and the areola become darker during pregnancy, this usually indicates that there is plenty of milk producing tissue. Has she had breast surgery at any time, which may have cut some milk ducts or nerves or for a breast abscess? Second, during breast examination, you have to look. Are the breasts very large or very small? Reassure the mother that small or large breasts all produce plenty amount of milk, but sometimes a mother may need help with attachment. Are there any scars which may indicate past problems with breastfeeding such as an abscess or surgery? Is either breast swollen with tight shiny skin? This suggests engorgement with edema. Normal fullness when the milk comes in makes the breast larger, but not swollen with shiny edematous skin. So if there is there redness of any part of the breast skin, if diffuse or generalized, this may be due to engorgement, and if localized, this may be a blocked duct in a small area, or it is mastitis, which is seen in a larger, clearly defined area. Purple discoloration on the breast suggests a possible abscess. So what is the size and shape of the nipples? Is it long or flat, inverted, or very big? Could their shape make attachment difficult? Look, are there any sores or fissures or a linear sore? This usually means that the baby has been suckling while poorly attached. Is there a rash or redness of the nipple? Third, in breast examination is you have to feel. Is the breast hard or soft? Generalized hardness, sometimes with several lumps, may be due to normal fullness or engorgement. The appearance of skin, such as shiny with engorgement or normal with fullness, and flexibility of the skin, such as turgid, should tell you which it is. Talk to the mother about what you have found. Highlight the positive signs you see. Do not sound critical about her breasts. Build her confidence in her ability to breastfeed. So look for the nipple size and shape. There are many different shapes and sizes of breast and nipple. Babies can breastfeed from all of them. Nipples can change during pregnancy and become more protractile or stretchy. Inverted nipples do not always present a problem. Babies attach to the breast and not to the nipple. If you think her nipples may be inverted, the best way to help is to build her confidence and provide good support from birth. Long or big nipples may also cause difficulties because the baby does not take the breast far enough back in his or her mouth. Help the mother to position and attach the baby so that there is a large amount of breast tissue in the mouth, not just the nipple. If the baby gags repeatedly because of a large nipple, ask the mother to express the milk and cup feed the baby for some days. Babies grow quickly and their mouths soon become bigger. So how do you assist the mother with inverted nipples? If the mother appears to have inverted nipples, ensure uninterrupted skin-to-skin contact immediately after birth and at other times. This is to encourage the baby to find his or her own way to the breast in his or her own time. So give extra help with positioning and attachment in the first day or two before the breast become full. Explain the mother with an inverted nipple that the baby latches on to the areola and not onto the nipple. Help the mother to find the position that helps her baby to take the breast. For example, sometimes leaning over the baby on a table so that the breast falls towards his or her mouth can help. If the mother appears to have an inverted nipples, suggest that she gently change the shape of the areola into a cone shape or sandwich using a C-shaped hole so that the baby can latch onto it. Explain that babies may need time to learn and then will latch on spontaneously. Suggest that the mother stroke her baby's mouth with the nipple and wait until the baby opens with a wide mouth before bringing the baby onto the breast. Teach the mother how to recognize effective attachment. Encourage the mother to help her nipples protrude before a feed. She can gently stimulate her nipple. Use a breast pump, another mild suction device, or someone else sucking if acceptable to draw out the nipple. Avoid artificial teats and pacifiers as these devices may make it more difficult for a baby to attach and take a large mouthful of breast. Prevent breast engorgement as this makes attachment difficult for the baby. If necessary, express and feed by cup while the baby learns to breastfeed. So you can use the syringe method as a treatment for inverted nipples. The mother must use the syringe herself so that she can control the amount of suction and avoid hurting her nipple. So take a syringe at least 10 milliliters in size and if possible 20 milliliters so that it is large enough to accommodate the mother's nipple. Cut off the adapter end of the barrel where the needle is usually fixed. You will need a sharp blade or scissors to do this. Reverse the plunger so that it enters the cut, now rough, end of the barrel. Before she puts the baby to her breast, the mother pulls the plunger about 1/3 of the way out of the barrel. Pulls the smooth end of the syringe over her nipple. Gently pulls the plunger to maintain steady but gentle pressure for about 30 seconds. Pushes the plunger back slightly to reduce suction as she removes the syringe from her breast. Tell the mother to push the plunger back to decrease the suction if she feels pain. This prevents changing the skin of the nipple and areola. So this is how you do the syringe method for inverted nipples. So step 1, you have a syringe. So you have to cut along the line with a sharp blade. And then next, you have to reinsert the plunger from the cut end. And the third, you put that smooth area over the nipple and gently pulls the plunger. This would suction the nipple coming out if it is inverted. So this is a clear picture of using an inexpensive, effective, homemade nipple puller. So you use a normal 10 ml or 20 ml syringe depending on the size of the mother's nipple. So you have to cut off the tip end of the syringe. Then reinsert the plunger from the cut end. So before feeds, you have to place the open end of the syringe over the mother's nipple and pull it gently to create a suction. Just enough to pull the nipple coming out, but not so much because this will hurt. So hold for about 30 seconds, release the suction, and latch the baby immediately. So, what is engorgement? How do we differentiate the normal breast fullness from engorgement? So, a normal breast fullness, when the milk is coming out, there is more blood supply to the breast as well as more milk. So, the breast may feel warm, full, and heavy, which is normal. To relieve fullness, feed the baby frequently and use cool compresses between feeds. In a few days, the breast will adjust milk production to the baby's needs. How about breast engorgement? If the milk is not removed, the milk, blood, and lymph become congested and stop flowing well, which results in swelling and edema. The breasts will become hot, hard and painful, and look tight and shiny. The nipple may be stretched tight and flat, which makes it difficult for the baby to attach and which can result in sore nipples. If engorgement continues, the feedback inhibitor of lactation reduces milk production. So what are the causes of breast engorgement? First, there is a delay in starting to breastfeed soon after baby's birth. Second, there is a poor attachment so that milk is not removed effectively. Third, there is infrequent feeding, wherein the baby is not fed at night or there is short duration of feeds. Do your practices help to avoid engorgement? If much engorgement is seen in a maternity facility, the pattern of care for mothers should be reassessed. Implementation of the 10 steps to successful breastfeeding prevents most painful engorgement. If you can answer yes to all of the following questions, there should be little engorgement in your facility. Ask yourself, is skin-to-skin contact practiced at delivery, which is the step 4 in successful breastfeeding practice? Next, is breastfeeding initiated within 1 hour after birth, which is again a step 4. Do staff offer help early and make sure that every mother knows how to attach her baby at the breast, which is part of step 5. If the baby Is not breastfeeding? Is the mother encouraged and shown how to express milk from her breast frequently? Also, in step 5 and in step 7, are babies and mothers kept together 24 hours a day or being roomed in? Is every mother encouraged to breastfeed whenever and for as long as her baby is interested, day and night? At least 8 to 12 feeds in 24 hours, which is a step 8 practice. And in step 9, are babies given no pacifiers, artificial teats, or bottles that would replace suckling at the breasts? So, to treat engorgement, it is necessary to remove the milk from the breast because this will relieve the mother's discomfort, prevent further complications such as mastitis and abscess formation. It would help to ensure continued production of milk, and it would enable the baby to receive breast milk. So, how do we help the mother to relieve engorgement? So, we have to check the proper attachment. Is the baby able to attach well at the breast? If not, help the mother to attach her baby at the breast well enough to remove the milk. Suggest that she gently express milk from her breast herself before a feed to soften the areola and make it easier for the baby to attach. If breastfeeding alone does not reduce the engorgement, advise the mother to express milk between feeds a few times until she is comfortable. Encourage frequent feeds. Apply a warm compress using a wet cloth to the areola area just before a feed to help get milk flow started. A warm bath or shower may also help the milk to flow. You can do a massage on the back and neck or other forms of relaxation that may help the milk to flow. Help the mother to be comfortable. She may need to support her breasts if they are large. You also provide a supportive atmosphere when breastfeeding. Build mother's confidence by explaining that soon the engorgement will be resolved. You also use cold compresses which may lessen the pain between feeds. So for black milk ducts and mastitis or breast inflammation, milk sometimes seems to get stuck in one part of the breast, and this is called a black duct. If the milk remains in a part of the breast, it can cause inflammation of the breast tissue or non-infective mastitis. Initially, there is no infection, and however, the breast can become infected with bacteria and is then infective mastitis ensues thereafter. Black ducts and mastitis can be caused by infrequent breastfeeding. Maybe because the baby wakes infrequently, hunger signs are missed, or the mother is very. Black ducts and mastitis can be caused by the following. There is inadequate removal of milk from one area of the breast. There can be a local pressure on one area of the breast due to the use of tight clothing. Lying on the breast, or there is pressure of the mother's fingers on the breast, or there is trauma to the breast. The black duct would cause a lump, red skin, and tenderness, but there is no fever and the mother feels well. Signs and symptoms of mastitis are the following. There is usually pain and redness on the area. The mother may manifest fever and chills. Others may be having tiredness or nausea, headache, and general aches and pain. Both non-infective and infective mastitis have the same symptoms. This is a picture of mastitis wherein you can have the swelling and tenderness on the area. Here's a comparison of a healthy breast and breast with mastitis. Take note in this area that there is an inflamed lobes in this area causing the skin redness. So how do we assess a mother with a black duck or mastitis? The important part of treatment is to improve the drainage of milk from the affected part of the breast. First, you observe a breast feed. Notice where the mother puts her fingers and if she presses inwards, perhaps blocking the milk flow. Notice if her breasts are very heavy. If the black duck or mastitis is in the lower area, lifting the breast while feeding the baby may help that part of the breast drain better. Ask about frequency of feeds and if the baby is allowed to feed for as long as the baby wants. Ask about pressure from tight clothes, especially bra, worn at night or trauma to the breast. So, treatment of mastitis, we have to explain to the mother that she must remove the milk frequently. And the best way to do this is to continue breastfeeding her baby frequently. Check that her baby is well attached. Offer the baby the affected breast first and help the milk to flow. Explain to the mother that she must gently massage the black duct or tender area down toward the nipple before and during the feed. Apply a moist, warm cloth to the area before a breastfeed. Check that her clothing, especially her bra, does not have a tight fit. Rest with the baby so that the baby can feed often. The mother should drink plenty of fluids. The employed mother should take sick leave if possible. And lastly, rest the mother, not the breast. If the mother or baby is unwilling to feed frequently, it is necessary to express the milk. So give this milk to the baby if the milk is not removed. Milk production can cease and the breast becomes more painful, possibly resulting to abscess. What would be the drug treatment for mastitis? Anti-inflammatory treatment is helpful in reducing the symptoms of mastitis. Ibuprofen is appropriate if available. A mild analgesic can be used as an alternative. So what are the indications if we will start antibiotic therapy? First, the mother has fever for 24 hours or more. Second, there is evidence of possible infection. For example, an obviously infected cracked nipples. Next, the mother's symptoms do not begin to subside within 24 hours of frequent and effective feeding and or milk expression. Next, the mother's condition worsens. The prescribed antibiotic must be given for an adequate length of time. 10 to 14 days is recommended to avoid. So what would be the implications of mastitis in the woman who is HIV positive? In a woman who is HIV positive, mastitis or nipple fissure, such as bleeding or oozing, may increase the risk of HIV transmission. So, if an HIV positive woman develops mastitis, an abscess or a nipple fissure, she should avoid breastfeeding from the affected breast while the condition persists. She must express milk from the affected breast by hand or pump to ensure adequate removal of milk. This is essential to prevent the condition becoming worse, to help the breast recover, and to maintain milk production. The health worker should help her to ensure that she is able to express milk effectively. Antibiotic treatment is usually indicated in a woman with HIV. The prescribed antibiotic must be given for an adequate length of time. 10 to 14 days is recommended to avoid relapse. If only one breast is affected, the infant can feed from the unaffected side, feeding more often and for longer to increase milk production. Most infants get enough milk from one breast. The infant can feed from the affected breast again when the breast has recovered. The health worker need to discuss other interim feeding options. The mother can decide to heat treat her expressed milk or give home prepared or commensurate formula. The infant should be fed by cup. Sometimes, a woman may decide to stop breastfeeding at this time if she is able to give another form of milk safely. She should continue to express enough milk to allow her breasts to recover and to keep them healthy until milk production ceases. So it is important for the mother, if she is having an option of interim feeding, that the milk is available, feasible, affordable, safe, and sustainable. How about the sore nipples? Breastfeeding should not hurt. Some mothers find their nipples slightly tender at the beginning of a feed for a few days. This initial tenderness disappears in a few days as the mother and baby become better at breastfeeding. If this tenderness is so painful that the mother dreads putting the baby to the breast or there is visible damage to the nipples, this soreness is not normal and needs medical attention. The most common early causes of nipple soreness are simple and avoidable. If the mother in your facilities are getting sore nipples, make sure that all maternity staff know how to help mothers get their babies attached to the breast. If babies are attached well at the breast and breastfeed frequently, most mothers do not get sore nipples. So how do we assess a mother with a black duck or mastitis? Do observation and history taking for sore nipples. You ask the mother to describe what she feels. Any pain at the start of a feed that fades when the baby lets go is most likely related to attachment. Pain that gets worse during the feed and continues after the feed has finished, often described as burning or stabbing, is more likely to be caused by Candida albicans or fungal infection. Look at the nipples and breast. Broken skin is usually caused by poor attachment. Skin that is red, shiny, itchy, and flaky at times with loss of pigmentation is more often seen with Candida. Remember, Candida and trauma from poor attachment can exist together. Similar to other parts of the body, the nipple and breast can have eczema, dermatitis, and other skin conditions. Here is a picture of a sore nipple. So there is a uh, broken skin due to poor attachment. Here is a picture of redness, redness on the nipple area, which is also caused by poor attachment. So observation history taking for sore nipples. So we have to observe a complete breastfeed. So you have to check how the baby goes on breast and his or her attachment and suckling. Notice if the mother ends the feed or if the baby lets go himself or herself. Observe what the nipple looks like at the end of the feed. Does it look misshapen or squash, red or have a white line? Check the baby's mouth for tongue tie and candida. Ask mother about previous history of candida or anything that might contribute to candida, such as recent use of antibiotics. If the mother is using a breast pump, check that it is appropriately positioned and the suction is not too high. Decide the cause of the sore nipple. The most common causes of sore nipples are poor attachment or secondary to engorgement or both caused by poor attachment. Decide the cause of the sore nipple. The most common causes of sore nipples, aside from the above mentioned, could be baby is pulled off the breast to end a feed without the mother first breaking the seal between the baby's mouth and the breast, a breast pump that may cause excess stretching of the nipple, and breast or rub against the breast, candida that can be passed from the baby's mouth to the nipples. The infant's tongue tie or short frenulum, which prevents the tongue reaching over the lower gum, thus causing friction on the nipple. So how do we manage sore nipples? First, we reassure the mother that sore nipples can be healed and prevented in future. So treat the cause of the sore nipples. Help the mother improve attachment and positioning. Show the mother how to feed the baby in different feeding positions. This helps to ease any pain mother is experiencing because baby will be putting pressure on a different area of the sore nipple and allows her to continue feeding while the nipple heals. Treat skin conditions or remove source of irritation. Treat candida both on the mother's nipples and in the baby's mouth. If the baby's frenulum is so short that the tongue cannot extend over the lower gum and the mother's nipples have been sore for 2 to 3 weeks, consider if the baby should be referred and the frenulum clipped. Suggest comfort measures while the nipples are healing. Apply expressed breast milk to the nipples after a breastfeed to lubricate and soothe the nipple tissue. Suggest comfort measures while the nipples are healing. You apply a warm, wet cloth to the breast before the feed to stimulate letdown. Begin each breastfeed on the least sore breast. If the baby has fallen asleep at the breast and is no longer actively feeding but remains attached, gently remove the baby from the breast. Wash nipples only once a day, as for normal body hygiene and not for every feed. Avoid using soap or nipples as it removes the natural oils. What does not help sore nipples? First, do not stop breastfeeding to rest the nipple. The mother's breast may become engorged, which makes it harder for the baby to attach to the breast, and the milk supply will decrease if the milk is not removed from the breast. Do not limit the frequency or the length of breast feeds. 1 minute of sucking with poor attachment can cause damage to the breast. 20 minutes of suckling with good attachment will not cause damage to the breast. Do not apply any substance to the nipple that would be harmful for the baby to take into his or her mouth, which requires removal before breastfeeding, or which can sensitize the mother's skin and make the nipple more sore. An ointment is not a substitute for correct attachment. Do not use a nipple shield or as a routine measure. A nipple shield may cause more problems. Some shields result in less stimulation of the breast and reduce the amount of milk transferred, which may lead to reduced production. It can affect the way the baby sucks, resulting in some soreness when it is stopped. It also presents a health risk to the baby from the possibility of contamination. So, how do we examine the mother's breast and nipples? After the baby is born, there is no need to physically examine breastfeeding woman's breasts and nipples. Always observe the condition of the mother's breasts when you observe a breastfeed. In most cases, this is all that you need to do. As you can see, most important things when she is putting the baby onto the breast or as the baby finished a feed. Examine the mother's breast only if a difficulty arises. Ensure privacy and ask permission before touching. Look at the shape of the breast and nipples. Look for swelling, skin damage, or redness. Look for evidence of past surgery. Talk to the mother about what you have found. Highlight the positive signs you see. Build her confidence in her ability to breastfeed. So how do we prevent breast engorgement? Fullness is not normal in the early days. Overfullness is not normal. So the following are the practices of the 10 steps in breastfeeding to prevent breast engorgement. For step 4, we have to facilitate skin-to-skin contact immediately after birth and initiate exclusive, unlimited breastfeeding within 1 hour after birth. For step 5, we have to show mothers who need help how to attach their baby at the breast and show the mother how to express their birth. For step 6, breastfeeding exclusively with no water or supplements. And for step 7, this is rooming in. Keep both the mothers and babies together in a caring atmosphere. For step 8, or the demand feeding, encourage babies to feed at least 8 to 12 times in 24 hours during the early days. For step 9, give no pacifiers, artificial teats. So how do we treat breast engorgement? First is we have to remove the breast milk, and this would promote continued lactation. Next, we have to correct any problems with attachment. The key here is there should be a good attachment in breastfeeding. Next, gently express some milk to soften the areola and help the baby's attachment. It is important that we breastfeed more frequently. You can apply warm compress to the breast before feeds and cold compresses to the breast after breastfeed for comfort. Build the mother's confidence and help her to be comfortable while breastfeeding. Black milk ducts and mastitis or breast inflammation may be caused by infrequent breastfeeding, inadequate removal of milk, or pressure on the part of the breast. So how do we treat mastitis or black milk ducts? First, we have to improve milk flow. Check the baby's attachment and correct, improve if needed. Check for tight-fitting clothing or pressure from fingers. You have to support a large breast to assist milk flow. So suggest the following. Breastfeed frequently. If necessary, you can express the milk to avoid breast fullness. You can do gentle massage towards the nipple. Apply a moist, warm cloth to the area before a breastfeed. Breast the mother, not the breast. And you can give an anti-inflammatory treatment or analgesic if the mother is in pain. Another is antibiotic therapy if the mother has a fever for longer than 24 hours or the mother's symptoms do not begin to subside after 24 hours of frequent and effective feeding and or milk expression, or if the mother's condition worsens. If a woman is HIV positive and develops mastitis or an abscess, she should avoid breastfeeding from the affected breast while the condition persists. Express the milk from the breast, which can be heat treated and given to the baby. Rest, keep warm, take fluids, take pain reliever, and give antibiotics. For the, for the sore nipples, you have to decide the cause, including observation of a feed. You have to examine the nipples and breasts. Reassure the mother. Treat the cause, which is the most common cause is poor attachment. Avoid limiting the frequency of feeds. Refer skin conditions. Look for tongue tie and other less common conditions to a suitably trained person and correct it. Relieving engorgement when a mother is not breastfeeding. So you have to support the breast well to make her more comfortable. You can apply compresses, warm or cold compresses to reduce swelling. Express enough milk to relieve discomfort. Expression can be done a few times a day when the breasts are overfull. It does not need to be done if the mother is comfortable. Remove less milk than the baby would take so as not to stimulate milk production. You have to relieve the pain by giving an analgesic such as ibuprofen or paracetamol. Some women use plant products such as teas made from herbs or plants or raw cabbage leaves placed directly onto the breast to relieve pain and swelling. How do we treat breast abscess? If mastitis is not treated early, it may develop into abscess. An abscess is a collection of pus within the breast. It produces a painful swelling, sometimes with bruising discoloration. An abscess needs to be aspirated by syringe or surgical drainage by a health worker. The mother can continue breastfeeding if drainage tube or incision is far enough from areola not to interfere with attachment. If the mother is unable or unwilling to breastfeed on that breast because of the location of the abscess, she needs to express her milk. Her baby can start to feed again from the breast as soon as it starts to heal. Takes usually about 2 to 3 days. Good management of mastitis should prevent formation of an abscess. Sometimes a nipple shield is offered as a solution for a baby who does not suck well or if the mother has sore nipples. Nipple shields may cause difficulties because they can reduce stimulation of the breast and nipple and thus can reduce milk production and the oxytocin reflex. There is also an increase of weight gain and dehydration among low birth weight. It also interferes with the baby suckling at the breast without the shield. It can also harbor bacteria and can cause thrush and infect the baby. It also causes irritation and rub the mother's nipple. The mother, baby, and health worker may become dependent on the shield and find it difficult to do without it. So you have to stop and think before recommending a nipple shield. If used as a temporary measure for a clinical need, ensure that the mother has follow-up assistance to enable her to discontinue using the shield. Candida infection or the thrush. Thrush is an infection caused by the yeast Candida albicans. Candida infections often follow the use of antibiotics to treat mastitis or other infections or if used following a cesarean section. It is important to treat both the mother and the baby so that they will not continue to pass the infection back and forth. Soreness from pool positioning can occur at the same time as Candida. So before starting to treat Candida, check for other causes of nipple pain such as poor attachment. So what are the signs of thrush infection? The mother's nipple may look normal or red and irritated. There may be deep, penetrating pain, and the mother may state that her nipples are burned and sting after a feed. The nipples remain sore between feeds for a prolonged period of time despite the correct attachment. This may be the only sign of the infection. The baby may have white patches on the skin, in his or her mouth. The baby may also have fungal diaper rash, and the mother may have a vaginal yeast infection. So, how do we treat thrush? We can use medication for the nipples and for the baby's mouth, and we have to continue that to use for 7 days after soreness has gone. Use medication that does not need to be washed off the nipples before a breastfeed. Some women find it helpful to air dry and expose the nipples to sunlight after each breastfeed. Change the bra and wash it in hot soapy water. If breast pads are worn, replace them when they become moist. If a vaginal candida infection is present, you have to treat it. The women's partner may also have to be treated. Wash hands well after changing the baby's diapers and after using the toilet. Stop the use of any dummies, pacifiers, teats, or nipple shields. If they are used, they must be boiled for 20 minutes daily and replaced weekly. An infant may have tongue tie because of a short frenulum, and this restricts tongue movement to the extent that the tongue cannot extend over the lower gum. The tongue then rubs against the base of the nipple, causing soreness.